All right, if you're still having a seat, that's totally fine. I'm going to go ahead and get started today. I'd first like to thank you all for attending today's Lunch and Learn presentation on stroke awareness. I'm just going to get started with some Buckeye Wellness announcements that we have coming up here shortly with related to some events and programs that are going on. First, I'd like to talk a little bit about the worksite wellness classes that we do have occurring, still happening over in the Ross, so right next door to us on 4:30 p.m., at 4:30 p.m. to 5:30 p.m. on Tuesdays. On Thursdays, we host a class on the campus side of things, so if you're coming from the academic side of things, we have an opportunity for you as well at 5:15 p.m. to 6:15 p.m. Our newer Strong by Zumba class is occurring over at Kinnear Road, 760 Kinnear Road, in room 215. So if you're interested in like a higher intensity boot camp type class, I'd say more open to both males and females for that type of setting. Not that Zumba isn't, but we noticed more of a gender inclusion of this type of class as well. Higher intensity class over at the Kinnear Road, and there's free parking over there as well. On Wednesdays at Martha Morehouse Pavilion, room 1046, if you're looking for an early morning start to your day for 6:15 a.m. Zumba Strong Boot Camp class, we have that offering for you as well. So we got some options that are still occurring with Buckeye Wellness Fitness classes. On Wednesdays, I lead a walk at 12 p.m. Right outside the Ross lobby. So with the weather getting nice, come on out and join me for a wellness walk. We'll walk around the Oval at Ohio State, about 30 to 40 minutes, about a 1 mile loop or so. So please join me for a walk. If you're looking to get out of the office on a Wednesday afternoon and meet me at the Ross Hospital Auditorium, you can sign up at linktohealth.osu.edu if you want to register. If not, walk-ins we totally accept as well. So please attend that if you're interested. Just want to put a blurb out there for one online program that we have, our Buckeyes Band Together for Wellness program. So as some of you may be aware of, the Office of Student Life here at Ohio State has adopted a 9 dimensions of wellness model. So when we're promoting wellness opportunities, we want to make sure that everyone understands it's more than just a person's physical well-being that goes into their wellness in general. It's their mental wellness and their emotional well-being, social well-being, career wellness. So this educational model, we've reached out to experts in the field at Ohio State and worked with them collaboratively to develop some learning modules and along as well with that some behavior tracking techniques that you can engage in each of these 9 different dimensions of wellness. So if you're interested, and once you complete all 11, the last one will be launched here shortly. You can earn 500 Your Plan for Health points for doing so. So the last one we have yet to launch is a social module. There will be a total of 11 modules because we broke down physical activity into 3 different modules. So if you're interested in looking at any previous Lunch and Learn presentations that we have, you can go to go.osu.edu/health and wellness lunch and learn. They are all saved to our media site. So we ask that you check that out if you're interested in seeing any previous Lunch and Learns, if you're interested to see any of our past speakers. We're always looking for new ideas, so feel free to email us at buckeyewellness@osu.edu, and you can get a hold of either myself or Lauren Batista, our program manager, and we'll be sure to reach out to you and get your questions answered. So without further ado, I'm going to go ahead and introduce our speaker for today's Lunch and Learn on secondary stroke prevention. So hang tight while I get his presentation loaded. Alrighty. So Noah Gross received his BSN at Alderson Broaddus College in Philippi, West Virginia. Following graduation, he worked as an intensive care nurse at the University of Kentucky Medical Center and received his master's degree in nursing acute care acute care practitioner. Sorry, I butchered that. He has been a member of the stroke and neurocritical care team at OSU since 2011. His clinical interests include acute management of ischemic and hemorrhagic acute intensive hypermanagement and neurocritical care. So without further ado, please join me in welcoming Noah Gross, nurse practitioner at the Ohio State University Medical Center.
All right, thanks everyone for having me today. Thanks for Buckeye Wellness for the invite and everybody. So I'm going to speak today on secondary prevention of stroke. As was mentioned, I work with the stroke program and I take care of these patients every day in the inpatient setting. So we start the secondary prevention when they're here and they continue that throughout their lifetime afterwards. Unfortunately, I do not have any disclosures, so I don't have anything to disclose. So the objectives for today, we're going to understand the definitions of stroke and TIA, the minor differences there, and then understand the differences between modifiable and non-modifiable risk factors. Pretty easy, so we'll knock that out. So some stroke statistics. So there's 795,000 new strokes every year that is accumulated across the United States. 600,000 of these are new and 185,000 are recurrent strokes. So this could be their second event, a TIA, then a stroke, any of that. There's one stroke in every 45 seconds in the United States. Nearly 3/4 of all strokes occur over the age of 65, though at the age of 55, your stroke risk does double every 10 years after that. Fewer than 1/2 of 911 calls are called when an individual that's having stroke symptoms within the first hour of their symptoms, which is significantly different if you have chest pain. If you have chest pain and arm numbness, you immediately call the EMS squad and go to the hospital. But with stroke, many people wait. They delay the care, which is bad on our end because stroke is only treated within the first couple hours, or acutely treated within the first few hours of symptoms. So 4 out of 5 families in the United States are going to deal with stroke at some point in their lifetime. Like me, I'm going to take care of a stroke patient. You're going to have a friend that's had a stroke, or you're going to have a family member that's had a stroke, or you might have a stroke yourself. So it is something that's very prevalent across the United States, but it's something that's also that we need to have more public awareness about. And it's a total cost on our financial or our medical care system about $65 billion a year, so very significant. So it's the leading cause of the leading cause of disability in the United States and Europe. And there's about 5.5 million stroke survivors alive today, and many of them have permanent stroke disabilities after their event. Some do not, but some do, minor to major. So it's the second leading cause of death in the world, and it is the 5th leading cause of death in the United States. There's about 130,000 individuals that die every year after having a stroke. In 2008, stroke was actually the 3rd leading cause of death in the United States, and I think in 1990, the American Heart Association came out with a 20 for 20, and they were going to reduce stroke and cardiovascular disease over the next 20 years. And in 2008, it dropped to 4th, and then in 2015, it dropped to 5th. They announced that in February of 2015. And women count for 6 out of every 10 stroke patients, or stroke deaths. So some more specific Ohio statistics. So from 1999 to 2009, stroke deaths in Ohio decreased, as well as across the United States. But in 2000 is when we became lower than the national average of stroke deaths. Like I said, it's also the 5th leading cause of death in Ohio. There were about 5,800 deaths in 2014 from stroke. And like I said, in 2000, that's when we dropped below the national average for stroke deaths. And then African American women and men are at a higher death rate for after stroke than Caucasians, at about 30 to 40% more. And then in Ohio, it's estimated that there will be a 61% increase by 2020 in stroke care to about $4.4 billion per year. So just recently, I got this emailed to me. So the Ohio State University is in a collaboration with multiple hospitals in Ohio. It's called the Coverdale, and they released this health value dashboard. So this grades the United States individual state against each other on the value of healthcare and the type of healthcare we're getting, as well as the patients and families that were affected by healthcare. Does anyone have a guess on where Ohio would be ranked? What? That was a good guess. Actually, we're 46th. Yeah, so we are very poor in the markers that they use in this study against the other 50 states in the country. So just to look at it, the health population, we're 43rd, and spending, we're the 31st, and it averaged out to 46th. And if you look at our population risk there in the Midwest, I guess, Ohio, Indiana, Kentucky, Tennessee, we seem to be the worst health of everybody else in the country. as well as the health value. And I've lived in all the states, Ohio, Kentucky, and West Virginia before, so I missed Indiana and Michigan already, but maybe one day. So the one good thing about stroke specifically that I saw in this, it was one of the healthcare systems that were highlighted in this study, and the patients that are receiving the clotbuster medicine when they come to the ER, we've actually are up to 25th, so we're actually doing relatively well in that metric for stroke care. So that's exciting for us, which improves outcomes and is going to continue that across those numbers. And this is a couple slides or a couple of maps that I found. So in 2004, the map on the right. So this shows the average time for a patient in each county to get to a stroke receiving hospital. If you can see, the dark blue is greater than 41 minutes. So with stroke being an acute emergency, a medical emergency that's reversible, 41 minutes is a big time frame, and that significantly decreases your outcomes. And in 2010, they released another map similar. The dark red is 45 minutes or longer. So if you can see, the areas are pretty much similar in where there'd be a couple areas that have changed, but it's still the significant decrease wasn't seen at that point. And then in 2012, 2013, telestroke kind of hit the market, and it was something that Ohio State jumped on board with as well as other larger stroke facilities. And the map on the right here shows stroke receiving hospitals that were mostly telestroke hospitals that were in collaboration with larger hub hospitals like Ohio State, and those circles around them are within 10 miles of a hospital that then could receive or give TPA more frequently. And then this recently was in December 2016, which that's the 30-minute window drive now in Ohio within a stroke receiving hospital. So we as a state have done a very good job of decreasing the time that it could take to have a patient received at a hospital for stroke care. And this is an example of our telestroke hospital. So we have 26 hub or spoke sites right now where we're in collaboration with them. We see them the physicians see them on the robots, and they evaluate them and then help the ER physician or provider at the outside hospital to say administer TPA or not and a transfer or not. So it's a great service that we give to a lot of hospitals across the state. And then with the other hub hospitals across the state, we've covered most of the state as well. So the definition of stroke and TIA. So by conventional definitions, the occurrence of focal neurological symptoms that last less than 24 hours is a TIA. So a focal neurological symptoms is a unilateral weakness or numbness. It could be a vision change, slurred speech, anything where you can't understand people's speech, or people aren't understanding what you're saying, aphasia, that's the term for that. These are things that last. They come on rapidly, acutely, and then they will either end rapidly or slowly diminish over the next 24 hours. With new imaging techniques, we do a lot more MRIs do now. Before previous definitions, they didn't. So now we'll do an MRI, and if you have any ischemic damage on MRI, you're then classified as a stroke, not a TIA. So in contrast to TIA, so the imaging, when imaging is not available, if you continue to have symptoms outside of 24 hours, you'll be classified as a stroke, not a TIA. And then central nervous infarction is described as brain, spinal cord, or retinal death attributed to ischemia based on a neuropathological, neuroimaging, or clinical evidence of permanent injury, which is imaging-based as well. The classification of these two definitions really don't mean as much in secondary prevention because we're going to treat them both the same now. So if you have a TIA, you're going to get the same risk modifications as you would if you had a stroke from a hyperlipidemia, or the things we'll talk about throughout the presentation. But people with TIAs are at a 10-fold increase of having a stroke over their lifetime than people that don't, which is a huge increase. Patients that have strokes as well are at a 25% increase of having a stroke within the next 2 years compared to patients or 1 in 4 patients will have a stroke that have already had a stroke within the first 2 years after their first event. So the epidemiology of stroke. So there's 3 major stroke definitions. So there's ischemic stroke and hemorrhagic stroke, and then hemorrhagic stroke is broken up into 2, which is interparenchymal hemorrhage and then subarachnoid hemorrhage. And 87% of all strokes are ischemic stroke, and that's what we're going to talk about today. We further classify those into large vessel occlusions, which are occlusions of your carotid, or small vessel disease, which are symptom or secondary risk reduction, hypertension, diabetes, hyperlipidemia, cardioembolism, patients with Afib that don't know about it or are subtherapeutic on their INR, which a clot goes from the heart to the brain. And then cryptogenic is a term which is we don't know why you had a stroke and we haven't figured it out yet. And about 30% of patients are cryptogenic in nature. So what is secondary prevention of stroke? So secondary prevention of stroke is pretty self-explanatory. We're going to prevent the next stroke from occurring. We want to prevent the next stroke and the recurrent stroke that's already happened. So some risk factors for stroke. So the non-modifiable risk factors are defined as factors that cannot be changed. And then modifiable are risk factors that can be changed, treated, or controlled, which we'll go over. So age. Age is a non-modifiable risk factor that we can't change. Like I said earlier, patients over the age of 65 are the ones that are the highest risk of stroke, though we are seeing patients with stroke a lot more that are younger, and even down into their 30s like I am, which is scary. But after the age of 55, you double your increase of stroke after every decade after that. So hereditary family history, if your family has a history of strokes, your mom has a stroke, your dad, your brother, your sister, especially before the age of 65, you're at an increased risk of stroke just because you're one of their family members. Race, like I said earlier, African Americans are at a higher risk of ischemic stroke, and that's mostly because they're at a higher prevalence for obesity, hypertension, hyperlipidemia, and diabetes, which makes them at a higher risk for stroke. Gender, women are at a higher risk of stroke than men. And like I said, patients that have had previous TIAs or strokes or heart attacks are at a higher risk of ischemic stroke as well. And so some modifiable risk factors. So hypertension is the leading cause of stroke as a secondary risk factor. Patients, it's the silent killer. Everybody knows about hypertension now as a public awareness thing. But it's the most significant controllable risk factor for ischemic stroke and stroke prevention. So if you have hypertension, you should have it treated. There's been a continuous association between high blood pressure and increased risk of ischemic stroke in multiple studies and multiple studies across different literatures. And if you are treating your blood pressure, you can have a 30 to 40% risk reduction in ischemic stroke just by treating it appropriately. You should have it treated if your blood pressure is greater than 140 over 190, and that's something that your primary care physician will treat and follow. The medications that are used, it's different than patients with heart attack where you need to be on certain drug medications, but with stroke, there's no specific medications that you need to be on. And then, as I said, that stroke reduction or stroke recurrence has decreased over time in the last decade or so, 2 decades. A lot of scientists are contributing that to the management of hypertension with patients across the country. So diabetes, it's one of the big 3, and diabetes is an independent risk factor for stroke, and it's treatable. You can treat it with insulin, you can treat it with oral medications, weight loss, any of the things that you need to do to treat that. Your diabetes should be on the high end of your health awareness that you're working on. Glucose control is recommended near normal, and then you should have an A1C monitored by your PCP, which was less than 7%, which is a relatively normal A1C. So dyslipidemia or hyperlipidemia is the modification as a primary serum lipid biomarker. So this is high cholesterol, and it's an important secondary risk factor for stroke as well. So we, as in the stroke population, only look at the LDL specifically, especially if you've had a stroke before. We're going to monitor that. We look at different triglycerides and HDL, but the LDL is our main one that we monitor. So studies have been shown modest relationship between total cholesterol or LDL and increased risk of stroke. So anybody with an LDL greater than 100, previously, like 2011-ish, we would be treating that patient. Now anybody that has a stroke in general will be discharged on a statin medication to bring their LDL less than 70. There's been some studies that have linked high triglycerides as well to large artery atherosclerosis, which is carotid atherosclerosis or coronary artery disease. And then there's a meta-analysis studies that have, including over 90,000 patients, that have shown that the larger reduction in LDL, which is a greater reduction of stroke risk, which is important to know. One of the main studies that came out that was specifically looking at stroke risk reduction with statin medications, which is called SPARKLE. So they looked at, they randomized patients with placebo versus a medication called Lipitor or atorvastatin, 80 milligrams, and they looked at endpoints over 5 years for just fatal and non-fatal strokes. And as you can see, the patients that were treated had an 11.2% stroke risk, and then the ones that didn't had a 13.1% stroke occurrence. So there was an absolute stroke risk reduction of 2.2% over 5 years. So this is the recommendation where we get your LDL less than 70 as soon as possible. So this is one of the things that I quote to a lot of patients every day. Cigarette smoking. If anyone still smokes, you should all stop, right? Smoking's bad. I think everybody knows that now. It's been proven multiple different ways. It doubles your chance for ischemic stroke as well as coronary artery disease. A lot of that's from the carbon dioxide and nicotine in your vessels that's causing them to harden more rapidly than they would normally. But it also increases your risk of coronary heart disease, peripheral vascular disease, cancer, lung disease, and many other chronic diseases as well. So quitting does matter. It's very important. If you are smoking, you should still quit regardless of how long you smoked. Observational studies have looked at this and they've demonstrated that stroke risk does decrease after quitting, and the elevated risk actually decreases even more after 5 years. So that's really important. And if you're a female and you're on birth control and smoking, that increases your stroke risk significantly more. So smoking and oral contraception is something you should really stop if you're doing. So alcohol consumption, another thing that pretty much everyone does. I mean, everyone has a drink here or there. There's a strong evidence that chronic alcoholism, though, and heavy drinking is a risk for stroke. And as you can see, there's a J. They call that a J-type shaped association with stroke risk. So initially, if you have moderate consumption, there's a reduction in stroke risk, which means if you're having one, I think the definition is 2 drinks per day for men and 1 for females, it actually reduces your stroke risk. And then if you are a heavy alcohol consumer or drink for a long period of time, it increases your stroke risk, but it's mostly through long-term abuse and things like that, which then causes you to have atrial fib and cardioembolism from cardiomyopathy. So obesity and physical inactivity is another modifiable risk factor. Being inactive, obese, or both can increase your risk of hypertension, hypercholesterol, or high cholesterol, diabetes, and heart disease and stroke. So it's real important to increase everyone's activity before or after you've had a stroke. Moderately active men and women have a 20% lower risk of stroke than patients that are not active, and those that are highly active are about 27% lower risk of stroke. So physical activity, why is that? Because physical activity lowers your blood pressure and your weight. It improves your glucose tolerance, and it promotes cardiovascular health, which is important as well. So patients that have had stroke already, we recommend that if all possible, that you have a 30-minute activity, physical activity a day. I think that's the recommendation across the board, even before you've had a stroke. Obstructive sleep apnea is another one. So obstructive sleep apnea has been linked with a lot of different chronic diagnoses, especially hypertension and diabetes, I think, and overweight. But patients that have persistent sleep apnea are approximately 1 to 3/4 of patients with stroke or TIA. So if you've had a stroke or TIA, you're more likely to have sleep apnea, or we'll find sleep apnea after you've had a stroke or TIA whenever you're in the hospital. So we send patients for sleep studies very frequently after they leave the hospital or when they're seen in the clinic to be evaluated for this so they can be fitted for CPAP or treat these things as well. And with treatment of their sleep apnea, patients' blood pressure decreases, they're more active, they're sleeping better, and all those kind of things. So it's a quality of life thing too. So atrial fibrillation. So this is the heart rhythm that we worry about most frequently with stroke patients. It's something that some people that have AFib know a whole lot. They feel it and they know they're having AFib, and others they're having it and they don't know. A lot of the patients that we see, unfortunately, didn't know they had AFib, and we find out whenever they arrive to the hospital when they're having a stroke. So if you have AFib and it's untreated, which means you're not on anticoagulation like warfarin or one of the new agents that are anticoagulants, you're at a 5-fold increased risk of stroke than you are if you are anticoagulated. So it's important that if you have AFib that you're on the correct medications. Multiple clinical trials have demonstrated that anticoagulation is in the prevention of thrombotic events among patients with non-valvular AFib. So it's superior effect than patients that are not on it. It's pretty obvious, but that's the truth. So your overall risk reduction when you're anticoagulated with AFib is 68%. So it's significant as well. And then your yearly risk reduction for patients that are anticoagulated with AFib is 1.4%. So of 1,000 patients that have a stroke a year on AFib, with AFib, and they're anticoagulated, we'll prevent 31 new stroke patients a year by that. So it's a significant thing as well. And it is safe. I wanted to make sure everybody knew that. With anticoagulation, you are at a risk of bleeding more because if we're thinning your blood with the medication that your physician or provider chose. And patients with warfarin versus placebo or even the new anticoagulants are at the same risk of bleeding after they're on the medications too. There are a couple surgical interventions that can happen for patients that have stroke for secondary prevention. So extracranial carotid disease, which is stenosis or hardening of the arteries of the neck, which we'll talk about here. And it is only really indicated whenever the patient's had a TIA or symptom. It's called symptomatic carotid stenosis. So patients that have symptoms of stroke, and then in our workup we find that they actually have this significant narrowing of the vessels that are providing blood flow to the brain, and that's when we would recommend surgical intervention. So there's been several randomized studies, and I kind of highlighted those here, that looked at not randomized and non-randomized trials that have compared surgical intervention with medical therapy alone. So these are the three main ones. If you look at the numbers didn't show up here, but the surgical arm has way less stroke after intervention than the medical arm, significantly. I think it's like 2.8 and less than 10% on the other ones, and then all the way up to almost 30% on some of the studies that they looked at. So if you have significant carotid disease, you should have it treated, and you should have it treated appropriately as well. So patients with ischemic stroke in the last 6 months with ipsilateral, which means stroke, carotid disease on the same side of their infarct, should have carotid intervention if they have carotid stenosis of severe to moderate, which is greater than 50% stenosis. Or if they've had a TIA or stroke and we find that, we will intervene within the first 2 weeks. A lot of times, depending on my attending, they'll stay in the hospital until the neurosurgeon can get them booked instead of letting them go home to come back. Your risk of stroke is increasingly more early on after stroke than it is outside of the first 2 weeks. So with technology, the first studies I mentioned were with the carotid endarterectomy, which is when they had to cut your neck and open up the vessel and scrape the plaque out. This CREST trial was taking that surgical intervention versus the one where they go in the groin and put the stent in like they do in the heart. And it's called CREST. And it was a multi-centered trial as well. And it showed no difference between the treating of patients with endarterectomy versus stenting. So that's why a lot of patients now go for stenting versus endarterectomy, unless they're younger or another reason that the surgeon wants to do. So the stroke treatments, patients with non-cardioembolic, which is patients that don't have Afib, atherosclerosis, small vessel lacunar, or cryptogenic infarcts are supposed to be on antiplatelet medications. So aspirin is the one. Aspirin, everyone knows aspirin. Agrinox is a smaller medicine that most people don't know that much about. And then Plavix is the other main one. So everyone knows aspirin and Plavix. From a stroke perspective, aspirin has beat everything. So we majority of the time only prescribe aspirin from a stroke perspective. There's some cases that a patient would be on aspirin and Plavix for a short period of time, but that's very rare in our setting. It's different than the cardiac world. All the studies that we've looked at, we've tried the aspirin and Plavix versus aspirin and all these different combinations, but aspirin always wins. So aspirin it is. And then non-valvular Afib, patients with Afib and stroke need to be anticoagulated. They need to be on either warfarin or one of the new agents like Eliquis, Pradaxa. There's a third one I can't remember off the top of my head. But these medications are, the warfarin medication, the significant downfall of warfarin is that you have to have like weekly lab draws to make sure your blood thinning is therapeutic within a level. The new agents, you don't have to take those lab draws. You just take the medication and it keeps your blood thin without having to have the lab draws or increase and decrease of medications. The bad things about the new medications that most of them don't have a reversal. So if you fall and bump your head or your hip or whatever, you're going to bleed, and there's nothing that we can reverse it with. Versus the warfarin, the tried and true medication, that we have medications now that we can rapidly reverse that if something would happen and you would need it emergently. So in general, I wanted to talk about some stroke awareness real fast. I know this was a secondary prevention talk, but stroke is treated emergently. It is time-based management. If you have stroke symptoms at home and you don't call the EMS or anything like that, we only have a certain amount of time to treat you if you're having a stroke with TPA or the clot-busting medicine. So within guidelines, you have within 4.5 hours from when your symptom onset happened, not when you showed up at the hospital. So it's important to call EMS if you're having numbness or tingling on one side of your body. If you're seeing somebody that's having facial droops and confused or things like that, make sure you call EMS. Patients that call EMS get faster treatment than they do if they drive themselves there or their family drives them there. So it's important to still call EMS and make sure that they're there to take you to the hospital. And you can decompensate quickly, and you might need help more than you think. So it's very important, though, that you call EMS. So act fast is the things that we use. So facial droop, uneven smile, arm or leg weakness. So arm, speech slurred, and then time. Time is of the utmost importance. And I can't emphasize time more than anything else. So in summary, real fast, risk factor reduction is the main thing that we can do to treat secondary strokes. So the things that we're going to do for you or for any of your family members that come through, we're going to reduce anything or we're going to try to prevent a stroke from recurring by reducing their risk factors. And the therapies we talked about previously through diabetic management, dropping their cholesterol appropriately, putting them on antiplatelet medications. Smoking cessation is important as well, and then treatment of sleep apnea. So any other questions for me? I couldn't do this without my family. This is my family, my mom and dad and my wife and my two boys, and my sister. But they're the people I do this for. So my grandmother's a stroke victim or a stroke survivor right now, and my grandfather on my mom's side my grandfather is also a stroke. He's a stroke victim. So it's close to my heart as well. Does anyone have any questions for me?
If anyone has any questions,
I'm going to pass. We have a couple microphones just so we have people live streaming in. Caitlin has a microphone over there. She's one of our Buckeye Wellness interns. So if you have questions, hang tight, and please feel free to raise your hand, and we'll come over and hand you a microphone. If not, if you could really fill out the evaluations, that would really be super beneficial for us. You can turn them in at either table up here, so you can make a pile of them up here next to our lovely wellness intern, Alina, or our lovely wellness intern, Caitlin. So we'll come around with the microphone. If anyone has any questions, feel free to stick around. If not, thank you so much, Noah, for your presentation today. It was a great presentation. So.
Thank you.
All right, we'll pass around the microphones for any questions, so please flag us down.
Okay.
Hey, Noah, I think we have one question over here.
Hi. Yeah, my mom had a stroke, and she worries about exercise. I mean, I think it might be partially an excuse, but she worries about exercising like too much. She often blames the stroke on having too much, doing too much, exerting herself too much with activity. She's 77 now. So how would you respond to that?
So I'm guessing, so a lot of patients that have strokes, they fatigue faster and they don't recover as fast as well. So I think limiting her to a smaller amount of any kind of exercise is going to benefit her. But if she's going too much, maybe she just needs to decrease that some and just try to do a little bit at a time. But I hear that a lot, and there's nothing that the exercise is going to do to harm her. I think the main thing is that she might have her symptoms might come back more, or she might be more fatigued the next day. That's a common complaint or side effect of stroke afterwards. Does that make sense?
Yes, yeah, it does. Thank you.
You're welcome.
Before we close?
Is this on? Okay. My husband actually had a TI, they called it a TIA at age 45. Is that more common in younger people? I mean, he didn't, as far as we know, it's not in his family.
No, a TIA, they typically don't. I mean, it's the same risk factors of stroke. You know, a TIA at 45 is young, and that's uncommon, yeah.
Last remaining questions before we close. I just want to put a plug in there. We have our health coaches outside. They have some events that they're advertising for as well. I know a lot of you guys stop by. I can see all the steamers there. But if you want to talk with them, they can sign you up for health coaching. There may or may not be some limited available biometric screenings to the right, so just check with Dixie who's doing those. And then there's stroke awareness checks outside to the left. So thank you, everyone, for participating in today's Lunch and Learn. And thank you again, Noah, for leading an awesome presentation. So have a great weekend, everyone, and enjoy the nice weather.